Hello everyone and welcome to our module on bone disorders. In the video on bone biology, I talked about how our bone is constantly turning over, meaning that osteoclasts are breaking down old bone and osteoblasts are laying down new bone. And if you understand that, then it's very easy to understand the bone disorders we'll talk about in this video. So osteoporosis, which I'm going to talk about in another video, is thinning of the bones, and this occurs when there is more bone breakdown relative to bone formation. Osteopetrosis is thick bones. In this condition, there's not enough bone breakdown and too much bone formation and the bones become thick. In rickets and osteomalacia, these are both nutritional bone disorders where there's not enough calcium around and therefore bone cannot be laid down normally. And then finally, Paget's disease, which we'll talk about in this video, is a disorder where there is too much bone turnover. Let's start by talking about osteopetrosis. In this disorder, there is defective osteoclast activity. And this leads to a situation in terms of bone turnover where osteoblastic activity is more than osteoclastic activity. As a result, there is more bone laid down and there is an increase in bone density. There are a number of forms of this disorder, and you don't need to know all the clinical details for step one, but you should be aware that there is an autosomal recessive form or infantile form that is the most severe form of the disorder. This form presents in infancy, that's why it's called the infantile form. And it's often caused by a genetic defect in a gene that codes for the enzyme carbonic anhydrase. This enzyme is required to normally make acid, and recall that osteoclasts have to make acid in order to break down bone. So when they can't do that, they can't break down bone normally. In addition, the kidney has trouble secreting acid, so these children often have a renal tubular acidosis. And then, as I said before, this is a very severe disorder, so these children also can have seizures and intellectual disability. There's also an autosomal dominant form, which is called Albers-Schonberg disease. This can present in adolescence. It's a milder form of the disease, and sometimes it's asymptomatic, and it's identified because an X-ray is done for another reason, and evidence of osteopetrosis is found. You might think that in osteopetrosis, because the bones are thick, that they would be super strong and never break, but this turns out not to be the case. The bones in osteopetrosis are prone to fracture. There's a balance in our bones between strength and flexibility, and in osteopetrosis they lose their flexibility and therefore they easily break. In addition, you can see excess bone laid down in the medullary cavity of the long bones, and this can lead to loss of the bone marrow. That can potentially cause pancytopenia. And when the bone marrow isn't making enough blood cells, the liver and the spleen can begin to make blood cells. This is called extramedullary hematopoiesis, and for this reason, in severe cases of osteopetrosis, you can see an enlarged liver and spleen. There can also be excess bone in the skull, and this can narrow the pathways by which cranial nerves exit the skull and lead to cranial nerve compression. So you can potentially see vision loss, deafness, or facial paralysis. And then finally, if there's bone deposition that narrows the foramen magnum, this can lead to hydrocephalus. It's very easy to recognize classic examples of osteopetrosis by X-ray. That's because the bones will be bright white. On the left side of the screen is a normal pelvis X-ray. On the right side of the screen is an X-ray from a patient with osteopetrosis. Notice how bright white all the bones are. Osteopetrosis is potentially curable with a bone marrow transplant. This is sometimes done for the more severe infantile form. Why is this the case? Well, that's because osteoclasts in our bones are derived from monocytes and macrophages, and here's a couple of monocytes on the screen to remind you of this. So if you replace the bone marrow and you replace the sick osteoclast with normal osteoclast, the bone turnover problem will go away and bones may return to normal. Moving on, let's talk about rickets and osteomalacia. These are both nutritional bone disorders. They are caused by either low calcium or low vitamin D intake. They're usually seen in the settings of famine and starvation, like this little boy shown on the screen here. In rickets and osteomalacia, there is poor mineralization of osteoid. So let's talk about what osteoid is. Osteoid is non-mineralized bone matrix. It's mostly proteins, and it's secreted by osteoblasts when they want to make new bone. Later, it becomes mineralized with calcium and phosphate. So in rickets and osteomalacia, the osteoid cannot be mineralized, but it keeps being laid down by osteoblasts. So where are you going to see osteoid? It's going to be at sites of new bone growth. In children, that will be at the growth plates, and in children and adults, that will be at sites of bone turnover. So in rickets, you have problems with osteoid deposition at the growth plates. In children and adults, you can see osteomalacia, which is problems with mineralization of osteoid at sites of bone turnover. To understand rickets, let's review what growth plates are. They're found at the ends of long bones in children. If you look at this X-ray on the screen here, this is the growth plate from a long bone of a child. The growth plates contain hyaline cartilage, and there are chondrocytes in the growth plate that grow toward the epiphysis, so that's this direction here. In the other direction, going this way, osteoblasts are laying down matrix. That's towards the diaphysis, or the straight part of the bone. And this is how the long bones get longer in children, and that's why their arms get longer and their legs get longer and they get taller. In rickets, the growth plates in children will thicken. This is because the chondrocytes continue to expand, although they display disorganized growth, and the osteoblasts lay down osteoid only. The osteoid does not become mineralized, so it just builds up, and the bone thickens from osteoid accumulation. And for this reason, you can see weakened bones and distorted bone growth, and you can also see thickening of the bone around the growth plate. Some of the clinical findings of rickets are shown in this slide. You can see epiphyseal widening of the long bones. The epiphysis is the end of the long bone right here, and it can become widened from osteoid deposition. You can also see bowing of the legs. This is called genu varum. I'll show you a picture of this in a minute. You can also see swelling at the costochondral junctions in the sternum. This can create a finding called the rachitic rosary, which I'll show you a picture of in a minute. And then in the skull, you can get craniotabes, which means a soft skull. The occipital and parietal bones are particularly vulnerable to this. This is the occipital bone here. This is the parietal bone in blue. They can become soft and collapse with pressure in children who have severe cases of rickets. Here's a picture of epiphyseal widening. You can see this child's wrist is swollen. That's because the epiphysis is accumulating osteoid. The growth plates in children with rickets can become abnormal. On the left side of the screen is a normal growth plate. On the right side of the screen is one from a patient with rickets. You can see that the growth plates are much wider than normal. You can also see that the bones are frayed and irregular. This is all evidence of rickets. And here is an example of the bowed legs of children with rickets called genu varum. Basically, the bones are weaker than normal and the child's weight presses down on them so they become bowed like this, a classic finding in cases of rickets. Your ribs meet cartilage in the front of your chest at a location called the costochondral joints or costochondral junction, and the ribs can become swollen at this point in children who have rickets, and this can lead to little bumps as seen in this child on the left side of the screen. You can also see the bumps here on this x-ray, and this is called a rachitic rosary. A rosary is a necklace with beads, and these look like beads on the rosary. So rickets is caused by a nutritional deficiency, but you will only see rickets in children because only children have growth plates. Osteomalacia, which is also a bone disorder caused by nutritional deficiency, can occur in children or adults. It doesn't occur at the growth plates. Instead, it occurs in areas of bone turnover throughout the body. It often presents as bone pain or tenderness. It's often in the spine, pelvis, and legs, and the bones become generally weak and they are prone to fractures. There are two classic X-ray findings of osteomalacia. One's called a pseudofracture. The other is called a loser zone, named for the person who first described it. These are caused by repaired stress fractures that are inadequately mineralized. They're also caused by erosion of bone by arterial pulsations. So the bone becomes weak, and when your arteries pulse with blood flow, that can erode the bone around the arteries. This is a pseudofracture shown here. You can just see this white line in a long bone. And this is a loser zone here. It just looks like a black space in a long bone. So I told you that rickets and osteomalacia are due to vitamin D and calcium dietary deficiency. So let's talk about that in a little more detail now. Usually these disorders are caused by a vitamin D deficiency, which in turn leads to a calcium deficiency. So what are some of the reasons a person could be vitamin D deficient? Well, if a mother doesn't take in enough vitamin D during pregnancy, her baby can be born with signs and symptoms of rickets and osteomalacia. Also remember that one of the major sources of vitamin D besides your diet is from the skin from sun exposure. So if a person doesn't get enough sun exposure and they don't eat enough vitamin D in their diet, they can become vitamin D deficient. Vitamin D is also a fat-soluble vitamin, so if a person has fat malabsorption, they can become vitamin D deficient. So you can see fat malabsorption in cystic fibrosis, pancreatitis, celiac disease, inflammatory bowel disease. All of these things could potentially lead to vitamin D deficiency and rickets and osteomalacia. And then finally, you need your liver and your kidneys to make the active form of vitamin D. So if a person has liver or renal failure, they cannot make enough active vitamin D, and that can lead to rickets or osteomalacia. You can also develop these disorders from calcium deficiency in absence of a vitamin D deficiency, but this is very rare. Usually people are deficient in vitamin D and secondarily deficient in calcium. You only see this if a person takes in very, very low amounts of calcium, but also happens to get enough vitamin D from the sun or their diet. So you can imagine, knowing what's on this slide, that the treatment of these disorders is very straightforward. They are treated with vitamin D supplementation and calcium supplementation. On your Step 1 exam, they like to ask you about the lab findings in rickets and osteomalacia. So people with these disorders have low serum calcium levels. Obviously, that's what leads to the problem mineralizing osteoid. And usually they also have a low vitamin D level because, as I told you before, these disorders are almost always due to a vitamin D deficiency. Let's talk about vitamin D in a little more detail. So there are two sources for vitamin D, your diet and your skin. Both of them can make an inert form of vitamin D, which then has to be activated by the liver and the kidneys. The liver hydroxylates vitamin D to make 25-hydroxyl vitamin D or calcidiol. The kidneys hydroxylate the vitamin again to make 125 hydroxyl vitamin D, which is called calcitriol, and this is the active form of the vitamin. Now that 25 hydroxyl form of vitamin D made by the liver is the storage form. It's constantly produced by the liver, and it's available in the body for activation by the kidneys as needed. This means that the best test to assess vitamin D status is the serum 25 hydroxyl vitamin D level. This form of vitamin D has a long half-life, and the liver production of this form of vitamin D is not regulated by PTH. So if it's low, it means you are not getting enough vitamin D from your diet or your skin. If it is normal, it means you are getting enough from your diet or your skin. The active form can go up and down depending on your parathyroid hormone level, but this is not true for the 25 hydroxyl storage form. Other findings in rickets and osteomalacia are shown here. The parathyroid hormone level will be high. This is the normal response of the parathyroid gland to low calcium levels, which you see in rickets and osteomalacia. There will be a low serum phosphate level. This is because the high PTH promotes excretion of phosphate by the kidneys. And then finally, there will be a high level of bone alkaline phosphatase. This enzyme level reflects osteoblast activity, and the osteoblasts are working very hard to lay down osteoid. They just can't lay down mineralized bone. Our next disorder is Paget's disease, which is also called osteitis deformans. This is a focal disorder of bone, so this is distinct from osteoporosis, osteopetrosis, and rickets and osteomalacia. Those disorders affect all the bones. Paget's disease develops focally, often in just a single bone, and this is a common disorder in older patients. The average age of diagnosis is about 70 years old. Paget's disease is a disorder where there is excessive bone remodeling or bone turnover. When this happens, there's overgrowth of bone at focal sites within individual bones, and the new bone that is laid down is abnormally large and deformed. The exact cause is unknown, but the primary cause is believed to be abnormal osteoclasts. Remember, osteoclasts are the cells that break down bone, and in Paget's disease, it's believed that they begin breaking down bone, and then osteoblasts lay down new bone, and you get excessive remodeling, and that leads to these focal sites of overgrowth of bone. Paget's disease evolves through a number of phases or stages. The first stage is called the osteolytic stage. This is the stage where osteoclasts are breaking down bone. And under the microscope, you can see bizarre-shaped osteoclasts. There are many of them. They are multinucleated, and these are involved in the osteolytic phase of Paget's disease. The second phase is called the mixed phase. That's because there is osteolytic and osteoblastic activity. In this phase, osteoblasts have begun laying down new bone. And then the final phase is called the osteosclerotic phase. This is where bone formation dominates, and you get this thickened abnormal bone present at focal spots within individual bones. Also in this phase, there is a hypervascularity that occurs because the bone has lots of blood vessels in it, and this will be important in a minute when we talk about some of the potential complications of Paget's disease. Under the microscope, the hallmark of Paget's disease is a mosaic pattern of lamellar bone with cement lines. So on the right side of the screen is normal lamellar bone. It forms these nice even lines. On the left side of the screen is bone from Paget's disease. You can see that it's all distorted. That's the mosaic pattern. There are also these lines called cement lines that are laid down. These are the classic findings in Paget's disease. Paget's disease may be asymptomatic. It's sometimes picked up when an X-ray is done for another reason and evidence of Paget's disease is seen. It often affects the long bones, but also the skull and the spine, and the most common complication is a pathologic fracture, classically a chalk stick fracture, where the bone breaks like a piece of chalk. I'll show you a picture of this in a minute. Patients can also have bone pain from microfractures within the bone, and sometimes patients who have Paget's disease of the long bones of the legs can develop bowing of the legs. This is a picture of a chalk stick fracture of the femur. You can see that the bone has just snapped like a piece of chalk. This is a pathologic type of fracture, often seen when there's something wrong with the underlying bone, like Paget's disease. Other findings of Paget's disease are shown on the slide here. Patients can develop an enlarged skull. Men who wear hats, which isn't very common these days, but if they do, can complain of an increased hat size. Cranial nerves can become compressed from skull enlargement. This can lead to deafness potentially. You can see radiculopathy at the spine if the bones of the spine compress a nerve root. And sometimes you can see erythema over the affected bone, especially when it's in the leg or one of the bones of the arms. You can see redness over the swollen bone, and this is due to the hypervascularity of the bone. So there's a rare complication of Paget's disease that they love to ask you about in step 1 of your boards, and that is high output heart failure. All that increased vascularity of the bone can lead to a connection between the arterial side of the vascular system and the venous side of the vascular system. This is called an AV fistula in the new bone, and when you have an AV fistula, blood bypasses the resistance vessels like the arterioles, and this can lead to high output heart failure. a rare but high-yield complication of Paget's disease to know about. Another complication you should be aware of is osteosarcoma. This is a rare bone tumor that I talk about in another video, but patients who have Paget's disease are at increased risk for this bone tumor. The classic lab finding of Paget's disease is an increased bone alkaline phosphatase level. This reflects the increased activity of the osteoblasts. And you can treat Paget's disease with bisphosphonates and calcitonin, which are two drugs also used to treat osteoporosis, and I talk about their mechanism of action and side effects in the video on osteoporosis drugs. Osteitis fibrosa cystica is the classic bone disease seen in hyperparathyroidism. I talk about hyperparathyroidism in the endocrine section in the video on the parathyroid gland, but I'll review the bone features of hyperparathyroidism here. So the clinical features of osteitis fibrosa cystica are bone pain and fractures. The high levels of PTH lead to bone resorption, and that leads to thinning of bones and weak bones. The classic cause of this condition is a parathyroid adenoma. This will lead to high PTH levels. That will promote bone breakdown and lead to osteitis fibrosa cystica. It will also lead to hypercalcemia. The phosphate level will be low, however, that's because parathyroid hormone promotes phosphate excretion by the kidneys. The two classic X-ray findings of osteitis fibrosa cystica are subperiosteal bone resorption and brown tumors. Parathyroid hormone promotes thinning of the cortical or hard bone, and this sits right below the periosteum as shown in this picture here. So subperiosteal bone resorption is commonly seen in the bones of the fingers. What you will see are irregular or indented edges to the bones. Brown tumors are also called osteoclastomas. These are collections of giant osteoclasts in the bone. They're mixed with stromal cells and matrix proteins, and they appear as big black spaces in the bone on X-ray. And shown on this slide are a couple of examples of brown tumors. You can see the red arrows on the left are pointing to black spaces in the long bones. Those are brown tumors. You can also see the white arrows on the right pointing to these big black spaces in the bones of the fingers. Renal osteodystrophy is a term that refers to the bone abnormalities that are seen in patients with renal failure. They can develop many of the bone problems we've talked about in this video. So patients who have renal failure are hypocalcemic. This is because the kidneys cannot make the active form of vitamin D, and therefore they become hypocalcemic. When the calcium is low, they develop hyperparathyroidism. So these patients can have problems from low calcium and from high PTH levels. So they can develop osteitis fibrosa cystica because their PTH level is high. They can develop rickets and osteomalacia because they are vitamin D deficient. They can develop osteopenia and osteoporosis, and this can lead to growth retardation in children. There can be bone pain and there can be fractures. This is all the constellation of bone problems that occurs in the setting of renal failure. And if you're ever given a tricky board question where they don't tell you the patient has renal failure, but they ask you for the cause of the bone problem, remember that when the PTH level is high, the phosphate level should always be low because PTH promotes excretion of phosphate. The only time you'll ever see the PTH level high and the phosphate level high is when the patient has renal failure and they can't get rid of phosphate. That will lead to high phosphate levels despite a high PTH level. I'll finish with this slide showing an algorithm for how to approach problems where patients have bone pain or easy fractures and you're asked to determine the cause. So first of all, look at the calcium and PTH levels. If they're both normal, then you're dealing with some primary bone problem. This could be osteoporosis, it could be osteopetrosis, it could be Paget's disease, or it could be a bone tumor. In all of these disorders, usually the calcium and PTH levels are normal. If they tell you that the calcium level is low and the PTH level is high, this is the normal response of the parathyroid gland to a low calcium level. So here the problem is with calcium, not the parathyroid gland. And this is usually a vitamin D deficiency. It may be a dietary deficiency, it could be not enough sun exposure, or it could be a malabsorption syndrome, but there's some problem getting enough active form of vitamin D in the body. If they tell you that the calcium level is high and the PTH level is high, this is abnormal in terms of the parathyroid gland. The PTH level should never be high when calcium is high, so this is telling you that the patient has a parathyroid problem. They have osteitis fibrosa cystica and they likely have a parathyroid adenoma. And that concludes our video on bone disorders.